Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, till now we have discussed the clinical manifestations of deep venous thrombosis. We will continue on forwards. So, the next thing is the diagnostic workup. Okay. So, what you will do in diagnostic workup? First, you will assess the clinical probability of having deep venous thrombosis. Then, divide it into low probability and moderate or high probability. If it is low probability, then you will go for D dimer. If D dimer is negative, then DVT is ruled out. DVT is negative. But if D dimer is positive, then you will go for ultrasonography of the limb. This is for low probability. For moderate to high probability, you will directly go for ultrasonography. But if ultrasonography does not confirm deep venous thrombosis, you will go for further investigations like MR venography. Okay. So this is the basic workup what you do in a patient with suspected with DVT. One more thing, according to Mcmaster book. So this is the general rule how we do. Okay. Next. Now you will assess the clinical probability by Wells score, and you will divide into low probability and moderate to high probability. Okay. Now you will assess whether you can advise the tests depending upon the availability of tests and investigations. Depending upon the availability of test and investigations, if test and investigations are availability of these are present, then what you will do, you go for test, then you will go for treatment of DVT. But if availability of these tests is negative and your clinical suspicion by Wells score is moderate to high, you will go for directly for treatment of DVT. If you don't have the availability, then thereafter you can confirm the DVT by test and investigations whenever you get that. Okay, whenever you have access to that. So that's about the brief and very good summary of the treatment of this diagnosis of this. So clinical probability. So low probability is nothing but no points. So proceed to D dimer. Moderate to high probability is nothing but at least having 1 point. So proceed to imaging. Okay. So Wells score integrates risk factor with clinical signs. That is nothing but Wells scores. Wells score integrates risk factor with clinical signs. Always assess the probability before ordering diagnostic tests. The probability is nothing but risk factors plus clinical signs. Okay. So D dimer. So something, it has a high sensitivity but low specificity. Age adjusted cutoff. So less than 50-year age, you follow the same range which is given by the pathologist. But for more than 50 years of age, this we will follow age into, for example, 51 years into 10 nanogram per milliliter. So the value will be 510 nanogram per ml. That means if a patient has more than who is aging 51 years and has more than 510 nanogram per ml of D dimer, that suggests the evidence of pulmonary embolism or deep venous thrombosis. But if the D dimer is negative, that will effectively exclude DVT in low probability cases. So you should not do this D dimer in medium to high probability cases. Remember this point. If it is even if it is negative, then also you should proceed for treatment if imaging modality is not available. So what is the demerits of this? False positives are common. For example, in infection also the D dimer is raised. In inflammation also the D dimer is raised. In cancer, pregnancy, these are all prothrombotic states. Remember what is D dimer? So there will be thrombosis going on. Okay, due to some prothrombotic factors. But side by side there is also antithrombotic mechanism which is working to balance the thrombosis and the thrombotic mechanisms. So whenever there is excessive formation of thrombus, there is excessive breakdown of the fibrinogen. fibrinogen, okay, into fibrinogen degradation products, FDPs, or D dimers, you can say. So D dimers are nothing but they are the breakdown products of thrombus. So whenever there is excess thrombosis, there are excess D dimers. So by that we infer that there is thrombosis. Okay. So it is best used in outpatient settings with low test probability. Avoid ordering in high probability cases because it has very little value. Okay. So what are the imaging modalities? Venous ultrasonography is the first line. Loss of vein compressibility is diagnostic. MR venography, excellent for pelvic or pregnancy related deep venous thrombosis when ultrasonography is equivocal, meaning it is neither showing negative, it is neither showing positive. Ultrasonography is equivocal. Ultrasonography is not revealing the results. So you will proceed for MR venography, excellent for pelvic and pregnancy related DVT. One more is contrast phlebography. Formerly it was gold standard, now reserved for interventional planning. Okay. So these two are the important investigations. Ultrasound non-invasive, widely available, highly sensitive for proximal DVT. MRV useful in obese patients or pelvic thrombosis. Iliac vein thrombosis. Okay. Pelvic thrombosis and obese patients it is helpful. Phlebography is invasive, used for complex cases or procedural guidance. So what is the approach now? Step 1, you assess the probability of well score. Step 2, if low probability D dimer. Step 3, if positive D dimer or moderate or high probability by well score, then you go for imaging. Step 4 is confirm diagnosis with imaging before initiating long-term therapy. Avoid first approach. Probability guided test improves accuracy and reduces cost. A bedside pearl. A negative D dimer in a low risk patient is reliable as imaging for exclusion. Clinical caveat, always consider alternative diagnosis like cellulitis, Baker cyst, ruptured, and lymphedema. So these three are important differential diagnosis. Okay. So what is well score? Well score is nothing but the it is a integrated, it is a combination of risk factor with clinical sign. Okay. By that you assess the probability of, so this is the well score. So at least one for deep venous thrombosis. See, well score is different for pulmonary embolism and for deep venous thrombosis. So in standard textbooks, both are discussed combinedly, deep venous thrombosis and pulmonary embolism, because both are linked together. So because we are discussing deep venous thrombosis, we will focus on deep venous thrombosis. So for deep venous thrombosis, low clinical likelihood of DVT if point score is 0. Moderate likelihood is 1 to 2. High likelihood if it is 3. That means if at least one factor should be there if you want to do consider imaging modality. So cancer will have one paralysis or recent cast. So this will cause immobility. No, this is a pre-thrombotic state. Bedridden for at least more than 3 days or major surgery within 3 weeks. Tenderness along distribution of deep veins. Tenderness along the distribution of deep veins. Entire leg swelling or unilateral calf swelling more than 3 centimeter. Entire leg swelling or unilateral calf swelling more than 3 centimeter. Pitting edema. Collateral superficial non-varicose veins. Cord we have discussed now. Thrombosed superficial vein, which you can palpable cord. Collateral superficial non-varicose veins. Alternative diagnosis at least as likely as deep venous thrombosis, that is -2. Okay. So remember, these are clinical important risk factors for DVT. What that? Active cancer, paralysis or recent cast, bedridden for more than 3 days or major surgery less than 3 months, tenderness along the distribution of tenderness, entire leg swelling, unilateral calf swelling, edema, okay, superficial veins. These are all risk factors for DVT. Now, this is important. For pulmonary embolism, you should have at least 4 points. 4 points to say as high risk for pulmonary embolism. If it is less than 4 points, then it is said as low risk for pulmonary embolism. So what are the things which you discuss? Signs and symptoms of DVT has a point of 3. Alternative diagnosis is less likely than pulmonary embolism, has a point of 3. Okay, that is one thing. Then three things have 1.5 times 1.5 score. Heart rate more than 100 beat per minute, 1.5. Immobilization for more than 3 days, surgery within 1 month, not 3 months, it is 1 month, 1.5. Prior history of pulmonary embolism or deep venous thrombosis, that has 1.5 point. So two things have 1 point. One is hemoptysis and second one is cancer. Okay, so that is the well score for pulmonary embolism. So 3 point is signs and symptoms of deep venous thrombosis. Alternate diagnosis is less likely than pulmonary embolism, and that also has 3 points. 1.5 point is heart rate more than 100 per minute, and immobility for more than 3 days, and surgery less than 4 weeks. That is also 1.5 points. And prior history of pulmonary embolism or deep venous thrombosis also has 1.5 points. Hemoptysis 1 point and cancer 1 point. So you can group it is like this. These are 3, these are 2, and these are 2. Okay. So if the score is at least 4, then it is considered as high risk embolism. Then you proceed for if it is I will just say here, if it is 4, then you will, it is considered as high risk for pulmonary embolism. Then you will proceed for HRCT, high resolution CT thorax. If it is unconclusive, you will go for CT angiography as well. CT, not angiography. Okay, CT angiography. You will go for something pulmonary scan. You will go for pulmonary scan. And if you don't yield result here also, and if DVT is present, then you will treat for pulmonary embolism also. High risk is there, but you have no signs in HRCT or pulmonary scan, but DVT is only sign is that DVT is present along with high risk pulmonary embolism, then you will treat for pulmonary embolism. So in case of deep venous thrombosis, well score matters more than your investigation. Remember this point. See here, how to decide whether diagnostic image is needed. Already said, suspected DVT or pulmonary embolism, assess likelihood by well score. Same thing repeating. Okay, so for deep venous thrombosis, no, not low, then go for imaging. If it is low and D diameter is normal, then no DVT. If it is high, go for imaging. But for pulmonary embolism, if the score is less than or equal to 4, then it is called as high, then go for imaging. If it is less than 4, then it is not high, then go for D dimer. If D dimer is normal, then no pulmonary embolism, similar to your this deep venous thrombosis. If D dimer is high, then go for imaging. Oh, so simple thing, very simple. Okay, so this is a how to decide whether imaging is needed or not. So in imaging test to diagnose deep venous thrombosis and pulmonary embolism. What are the imaging tests you will do? We have discussed. Now it is a flowchart. So DVT imaging test is you will do for venous ultrasound. If it is non-diagnostic, then you will go for MR venography, CT venography, or phlebography. If it is diagnostic, then stop here only. Okay. Pulmonary embolism chest, you will go for chest CT first. If chest CT is diagnostic, then stop. But if it is non-diagnostic, or if it is unavailable or unsafe, then you go for lung scan. If lung scan is diagnostic, then stop. If lung scan is non-diagnostic, then go for venous ultrasound. If venous ultrasound is positive, then treat for pulmonary embolism. If venous ultrasound is negative, then again you go investigate more. You will go for transesophageal echo or MR, magnetic resonance venography, or invasive pulmonary angiography you will go for, because the risk is high. So I said no, well score matters more here than investigations. If well score is high, then you go on doing investigations till you find the clue. And according to Mcmaster textbook of medicine, if you don't have availability and the risk is high, then straight away Mcmaster it will come says that go for treatment. Straight away it says go for treatment. If there is no contraindications for anticoagulation therapy, you go for anticoagulation therapy. Now the management. Okay, so first management we will discuss. So management can be divided into 3 things. So initial therapy, first one is initial therapy, second is primary or advanced therapy, then duration of therapy. Okay, so initial therapy is usually anticoagulation. This is the foundation of treatment. In advanced therapy, you will have a catheter directed thrombolysis. What you will do, if this is the vein and this is the thrombosis, you will insert a catheter here, and through that you will give tissue plasminogen activator, and you thrombolize the clot. You will do thrombolysis of the clot. So that is catheter directed thrombolysis. Or if anticoagulation is not possible, catheter directed thrombolysis is not possible, then if the patient has high risk of pulmonary embolism, in those patients who are having proximal DVT, you will place inferior vena cava filters. Okay. Okay. Now we will discuss individually these things. Now, what number? Okay. So initial therapy is, first one is novel oral anticoagulants. These are preferred nowadays because they don't require monitoring and they have less drug interactions. They don't require monitoring and they have less drug interactions and less chances of toxicity. That's why novel oral anticoagulants NOACs are preferred. Which are those? One is rivaroxaban, second is apixaban. Monotherapy is enough. So these are generally factor 10 inhibitors, factor 10 inhibitors. So just to understand these drugs, I will give a summary. So how you will anticoagulate a patient? So either you can suppress the, one thing is you will suppress the production of coagulation factors, for example 2, 7, 9, 10. So these factors are vitamin K dependent, vitamin K dependent. So you can use something called as vitamin K antagonists, VKA, like warfarin for anticoagulation. But the problem with this is the effect is not immediate. The effect is not immediate. Why? So the coagulation factors which are already synthesized, they will be present for some days, say for 3 to 5 days. And when you are giving warfarin, uh, it will take some time to have effect. But once it takes some time, it will act for a long time because production is blocked. So production will take again time to reinitiate the production. It will take time. Restart the production. It will take time. So vitamin K antagonist, when you use, they will take time to act as well as they will take time to wheel off their effect. Okay, that you should remember. This is one thing. Second thing is, see, under the presence of factor 10, prothrombin prothrombin is converted to thrombin, and this thrombin is important for plate thrombus formation. So factor 10A inhibitors act here. Okay, factor 10 inhibitors act here, and prothrombin is inhibited by something called as dabigatran. Dabigatran. Okay, thrombin is direct. Sorry, not dabigatran. I'm very sorry. So factor 10A is inhibited by these novel oral anticoagulants (NOCs), and direct thrombin inhibitor is dabigatran. So it will sit at a site on this thrombin and it will block the production of this the action of this thrombin, dabigatran. This will also take time. Okay, dabigatran. And there is one more anticoagulant which acts on factor 10A, that is uh, ido idoxap, something like that we will discuss. Okay, so this you just remember. Okay, so these are called as warfarin anticoagulants and these are called as non-warfarin anticoagulants. Okay, okay. And heparin, what it does? Heparin, it will increase the activity of naturally present antithrombotic agents. What does heparin does? How does heparin act? Heparin will increase the activity of antithrombin 3. Antithrombin 3 is nothing but the naturally occurring anticoagulant. That's how heparin will act. Heparin has two forms: unfractionated heparin and low molecular weight heparin. So what is the disadvantage? Unfractionated heparin has increased risk of heparin-induced thrombocytopenia, whereas low molecular weight heparin has decreased incidence of heparin-induced thrombocytopenia. That you should remember. Okay, and low molecular weight heparin and unfractionated heparin, they act immediately. Immediately they will act. Unlike the warfarin, which will take time to act. Okay, so edoxaban is the one factor 10 inhibitor that will take time. It is a factor 10 inhibitor, but it will take time to act. That is one thing you should remember. Okay, that's about the basics of anticoagulants. Now, initial therapy is anticoagulation. Okay, if it is not contraindicated. First line preferred is non-novel oral anticoagulants, rivaroxaban or apixaban, or you can give parental bridge. Okay, for example, low molecular weight heparin. There are two: enoxaparin given twice daily, dalteparin given once daily, or unfractionated heparin you can use. So when you use this low molecular weight or unfractionated heparin, when you are using dabigatran or edoxaban, no, these two things for long for say for short term or for long term, medium term or long term, for 3 to 6 months or for lifetime, if you are using these two, dabigatran or edoxaban, they will take time to act. So but these low molecular weight heparin and unfractionated heparin, they will act immediately. So that's why what you will do, you will give this low molecular weight heparin for 5 to 7 days or unfractionated for 5 to 7 days, then that is followed by dabigatran or edoxaban. Okay, so that is a parenteral bridge therapy which is given in case when you are using dabigatran or edoxaban. If you are doing this one, then no parenteral therapy is required. Bridge therapy is not required here. Now warfarin. Again, warfarin will take time to act. It requires 5-day overlap with parenteral anticoagulants until the INR is 2 to 3 for 2 consecutive days. Okay, that means parenteral bridge is required whenever you are using dabigatran, edoxaban or warfarin. Three things: dabigatran, edoxaban and warfarin. Okay. Novel oral anticoagulant simplify therapy. No monitoring is required and fewer drug and food interactions. Low molecular weight heparin is preferred in pregnancy because it does not crash the placenta. And also in cancer patient it is preferred. Pregnancy and cancer, LMWH is preferred. Warfarin is still useful in patients with mechanical heart valves or severe renal impairment patients. So patients with mechanical heart valves and severe renal impairment, you prefer warfarin. Mechanical heart valves or severe renal impairment, you prefer warfarin. Low molecular weight, low molecular weight heparin, you will prefer in pregnancy and cancer patients. Okay. Now, advanced therapy, catheter-directed thrombolysis. This is done indicated in phlegmasia cerulea dolens or when there is extensive iliofemoral, both iliofemoral deep venous thrombosis. This is best in patients with low bleeding risk. Low bleeding risk. Bleeding risk. Okay. This provides rapid clot resolution, reduces the risk of post-thrombotic syndrome, but it requires specialized centers. Inferior vena cava filters. This is indicated only if absolute contraindication to anticoagulation is there. For example, if the patient has active healing, like active peptic ulceration or intracranial bleed, active intracranial bleed, or recent history of stroke or recent history of surgery. Okay, all these are contraindications for anticoagulation. Then you will place IVC filters. And where when it is considered, this is considered two things. It is considered. One is absolute contraindication to anticoagulation. That another thing is recurrent venous thromboembolism despite therapeutic anticoagulation. Recurrent venous thromboembolism despite therapeutic anticoagulation. If the patient is developing again and again VTE, then also you will place IVC filters. This is not for routine use. Long-term filters increase the risk of recurrent DVT. Retrieval is recommended once indication resolves. Means if the that factor which is causing VTE, if it is gone, then you should remove that filters. Okay, IVC filters, because they too have increased chances of uh, risk of recurrent deep venous thrombosis. Now, what is the duration of therapy? Till what time you will give that? This is tailored to the risk of the patient. If the risk is transient of, or if it is a reversible, if the risk is transient and reversible, if the risk factor is transient or reversible, for example surgery, then the usual duration is 3 months. 3 months. For unprovoked or persistent risk factor, if the risk factor is persistent, then indefinite therapy is given if bleeding risk is low. If bleeding risk is low. Next thing is, if active cancer is there, then indefinite therapy is required. And what you will use? Low molecular weight heparin is preferred, or even you can use novel oral anticoagulants also in active cancer patients. So in three conditions, so in one condition, that is when the risk is transient or if the risk is reversible, then you will give usual duration therapy is 3 months. But if the risk is persistent, or if the patient is having, or if it is unprovoked DVT, for example, the patient is having some hereditary thrombophilia like things. So it is indefinite therapy. And for active cancer also it is indefinite therapy. Reassess the bleeding risk periodically. Cancer associated thrombosis. Low molecular weight heparin is historically preferred, but novel oral anticoagulants are increasingly used. Extended therapy reduces recurrence but increases the risk of bleeding. So, balance is the key. So, some upgraded things. Compression stockings may reduce the risk of post-thrombotic syndrome, but this is not. Books say don't give compression stocking to reduce the risk of post-thrombotic syndrome. But the other thing which the book says is that you can use compression stocking in patients who have already developed symptoms of post-thrombotic syndromes. There they can have some symptomatic relief when they use compression stockings, not before the development of PTS. Now it is not advised. Okay. Then lifestyle measures, weight reduction is very important, smoking cessation, mobility promotion. Okay. Monitoring is required. This is important. What you will monitor? Renal function test should be monitored. Drug interactions with NOACs should be monitored. Okay. Management is dynamic. It requires individualized approach. Patient education on adherence and bleeding signs is important. So you should counsel the patient to watch for any bleeding signs, bleeding in the skin or bleeding in the mucous membrane. Okay. You should counsel the patient for that. So you have known the duration of the therapy also. Okay. Now this is a good management frame algorithm of lower extremity deep venous thrombosis, which is given in the Mcmaster textbook of medicine. So we'll break it down now. Suspected DVT. So assess the clinical probability by well score. Okay. So if the clinical probability, let us say it is high or intermediate, then you order the laboratory tests, baseline laboratory tests like CBC, blood group, APTT, INR, serum creatinine. So these 4 baseline blood tests you order. Baseline blood tests. CBC, blood group, APTT, INR, creatinine. Okay. Now you will see whether there is any contraindications to the anticoagulant treatment. If there is no contraindication to anticoagulant, then you will start treatment with low molecular weight heparin or unfractionated heparin or fondaparinux or directly acting oral anticoagulants. Okay. You will start the therapy if there is no contraindications to anticoagulant treatment. What are the contraindications to anticoagulant treatment? So any active bleeding, example peptic ulcer, okay, or intracranial bleed, or recent stroke within 3 months, you can say stroke or surgery, history of stroke or surgery, or if the patient has thrombocytopenia less than 50,000 platelets, if the count is less than 50,000. So these are all the risk factors for contraindications to this anticoagulation treatment. Okay. So directly you will start, if the risk is high or intermediate, depending on the well score, you will start for anticoagulation therapy if there is no contraindication. If there is contraindication, then you will not start anticoagulants. Okay. Now depending on the clinical probability of DVT, you will perform the diagnostic test. That means if the risk is high or intermediate, you will not perform any diagnostic test. Directly you will give the anticoagulants, then you will confirm the DVT. If there is no contraindication, directly you start anticoagulation treatment, then you will confirm the DVT by imaging modalities. If there is contraindication, then you will wait for confirmation, then you will give anticoagulants in cases of high or intermediate. But when the probability is low, now you will ask yourself question, if the diagnostic tests can be performed immediately. If no, then you get these 4 baseline blood tests, then again you will go for the same thing, go for anticoagulant if there is no contraindication for anticoagulant treatment. If the blood tests are available, then you will perform first the blood test, then you will give the treatment. Okay. But one thing to remember is, in high or intermediate cases, first you will give treatment, then you will confirm your diagnosis in high or intermediate. And generally in low well score, first you will confirm, then you will give anticoagulation treatment. That's the thing. Okay. Now, if DVT is excluded, then no further treatment is required. Okay. If DVT is confirmed, one thing, if DVT is confirmed, then you will ask yourself the question whether it is extensive early proximal DVT, whether it is extensive early proximal DVT, for example, whether it is iliac DVT or femoral DVT or popliteal DVT. Okay, these are all proximal DVT. Whether there is extensive early proximal DVT, so we will go this way. No, it is not extensive proximal DVT. Then again, you will ask the question whether there are contraindications to anticoagulation treatment. Then there is no contraindication. Then you will see whether there is coexistent malignancy. And if the answer is no, then you will start or continue treatment with low molecular weight heparin, unfractionated heparin, fondaparinux, or DOAC. DOAC. Now we will go this way. There was extensive, I will just remove this. Okay, that means if there is no history of extensive early deep venous thrombosis and there are no contraindications to anticoagulation therapy, and if the patient is a cancer patient, then if the patient is not a cancer patient, then you will continue the treatment with low molecular weight heparin, unfractionated heparin, fondaparinux, or directly acting oral anticoagulants. You will start or you will continue. Okay. Now DVT is confirmed. Okay. If there was extensive early proximal DVT and there are no contraindications to anticoagulation treatment, then you will start again this no contraindication, you will start this treatment with anticoagulation. But if there is contraindication to anticoagulation, then you will go for inferior vena cava filter. Any contraindication, you will go for inferior vena cava filter. For coexistent malignancy, you will give low molecular weight heparin for 3 to 6 months, followed by long-term vitamin K agonist, DOAC, or low molecular weight heparin. So similar thing. So the main khulasa, the main conclusion from this is, I will just conclude it in one way. So just you remember, so in high or intermediate cases, you will start treatment before your diagnosis is confirmed. In low cases, you will start the treatment after your diagnosis is confirmed. If there is any contraindication to anticoagulation, you will go for IVC filter. That's all. Now duration depends upon the condition. If it is cancer patient, lifelong. If the factor is persistent, lifelong. If it is reversible factor or it is transient factor, for example surgery, then it is for 3 months. So first DVT, first episode of DVT, it is 3 months. Recurrent episodes, you rule out any thrombophilia like thing or anything which is persistent, and if it is present, then you will give for lifelong. Okay. Now again, you will ask whether any contraindications to vitamin K agonist is there. If yes, then you will continue with these only. If there are no contraindication in patients not receiving DOACs, start vitamin K agonist from treatment day 1 in combination with unfractionated heparin, low molecular heparin, fondaparinux, and discontinue heparin or fondaparinux after more than or equal to 5 days, provided INR is more than 2 for 2 consecutive days. It should be between 2 to 3 INR. So transiently used anticoagulants are 3. Remember, either it is unfractionated heparin, or it is low molecular weight heparin, or it is fondaparinux. These are the 3 transiently used when you are not using NOACs or DOACs. Okay, meaning the big this one apixaban or rivaroxaban. And unfractionated heparin is safe in renal patients, whereas LMWH is not safe in renal patient. It is long acting, it is short acting. Okay, and this you will prefer in pregnancy and cancer patient. Okay, so that's about the management algorithm for patient with deep venous thrombosis. And also when you are using the dabigatran, and so again the dabigatran and edoxaban also have less you no need for monitoring, and they have less drug interaction. That's right. But because they are late acting, you require a bridging parenteral therapy there also, and warfarin, they are also non-warfarin drugs. So that's about the management therapy. I think we will conclude here only and discuss the remaining topic in the next class. We'll finish it off. Thank you.